y'all know I don't like the F word in labor unless it's the literal F word, and in that case it is my mantra. Hello everybody, welcome back to my channel. My name is Elizabeth, also known as Nurse Zabe, here on YouTube, Instagram, and TikTok as well if you want to follow me over there. And I am a labor and delivery nurse, postpartum nurse, certified childbirth educator, and mom to 3. And of course, I want to thank you guys all so much for watching, and definitely leave a comment and a thumbs up. That super helps with the algorithm. But today we are going to be jumping in with a video all about 10 things nobody tells you about inductions, because I have so many patients come in with many of the same misconceptions or misunderstandings or just lack of knowledge about the induction process that is about to be occurring and happening with their body. So if you have an induction scheduled, or if you're thinking that you might need one or that you might want an induction, definitely go ahead and watch this video so that you can learn 10 things that nobody told you about inductions. So the first thing that I want you to know about induction is that there are actually 2 separate classifications of inductions. We have medical inductions and elective inductions. And with an elective induction, that will not occur until 39 weeks or greater. But with a medical induction, which means that medically it is safer either for you, for baby, or for both of you guys, for labor and delivery to occur before your body goes into labor by itself. Now, it can be a little bit tricky because often we think elective induction is like you're sick of being pregnant, but there are some things that sound medical that actually classify as an elective induction. For instance, some providers might encourage an induction of labor if you are of advanced maternal age greater than 35 years old, or if your baby was conceived through in vitro fertilization or IVF. That might be an indication. The literature supports that induction might be a safer route, but that is still actually considered an elective induction. So there are those 2 separate types of inductions. And with an elective induction, there are many reasons why you might want an elective induction. And it is not my job here to tell you which reasons are valid and which reasons are not valid. Quite honestly, that is a conversation that you need to be having with your provider. I think elective inductions get a really bad rep, and for me personally, I always felt that going to labor on my own, if that was a possibility for my body and for my baby, was the best choice for me. But you might look at the risks and benefits and kind of decide that an elective induction might fit you and your family and what's going on in your life a little bit better. So I don't think that all inductions are bad or evil by any means. I know a lot of times you will have people coming from a place where they feel like inductions lead to bad outcomes, and really we actually have some studies that support that inductions at 39 weeks can still have good outcomes. And so it really needs to be a decision between you and your provider. You shouldn't be forced to have an induction at 39 weeks that's elective, but if it is something that you're interested in, it's definitely a great conversation for you to have with your provider. The trial that I'm referring to is the ARRIVE trial, which that's a whole video on its own. That trial has a lot of nuance and caveats, and it's not something that we should say everybody should get an induction at 39 weeks. But what that trial did support is that an induction at 39 weeks can still have good outcomes if, and only if, and this is so important, you have a provider that is incredibly patient and incredibly gentle at nudging the body into labor, because that is going to be what's key. You're deciding if you want to do an elective induction or not, or you're discussing a medical induction that you would either like to decline or accept. Ask them what their normal induction process looks like. How long will they allow, right? Even though they're not allowing, how long would they like for that induction process to take? And if they're not somebody who's preaching that it can take a few days, that patience is required, then that might be a red flag that they are not going to be following the things that make the ARRIVE trial have better outcomes. The other thing that I think is really important to know about inductions is something called the Bishop scale. So not all providers are going to technically do the Bishop scale and give you a point-by-point number, but a lot of times they are when they check your cervix in the office, if that's something that you consent to. If you're needing a medical or requesting elective induction, then they will actually go through with that cervical exam and use the data that your cervix is showing us for how ready you are for labor and how likely that induction is going to work and how much time that induction is going to take. Based on where your cervix is in your vagina, is it really far back or has it come forward, how soft or firm your cervix is, how thin your cervix is, how open your cervix is, and then also where your baby is in the pelvis. Those All of that information will be kind of converted into a 0 to 1, 2, or sometimes even 3 range, and then calculated. And a Bishop score that is greater than 8 is one that is most likely going to result in a vaginal delivery. A Bishop score of less than 8 means that those inductions are less likely to result in a vaginal delivery. So what can we do with that information? We can decide if it's an elective induction that maybe we want to give you some more time, or if it's a medical induction that we might need to do something called ripening before the induction occurs. A lot of people have not heard of ripening before, but this is another thing that we sometimes will do if your cervix is closed and long, but for a medical reason it's safer for your baby to be earthside. Then one thing that we can look at is ripening the cervix, or kind of getting it started. And often how we do a cervical ripening is with a prostaglandin. So this would be either Cervical or Cytotec, one of those synthetic prostaglandins that can help the cervix to thin out. It helps break down those collagen binds in the cervix and may start that oxytocin prostaglandin kind of positive feedback loop that we can see going that can get labor started. So often with a ripening, you'll come in the evening and get 1 dose of this medication and then sleep throughout the night and start your induction the next morning. Some providers will even give you the medication, monitor baby, and then send you home to come back for an induction in the near future. So ripening is something that we can consider if that Bishop score is a little bit lower than where we would like to start, to help ensure that your body gets primed and ready for labor. Because the induction process can take a really long time. There are many steps that we work at. First, we're going to work at ripening or thinning out that cervix, getting it ready for labor. Then we're going to work on contractions to bring the baby down. We might even do some manual dilation of the cervix, which we'll talk more about in a little minute. But there can be many steps to getting your body actually going into labor. At any point in this process, your body might take over and the induction process in effect stops and labor continues on its own. But sometimes it can take a lot of time, maybe several days. Maybe we let you rest overnight and start back in the morning, or maybe you've been on Pitocin at a high dose for a while and we actually take a break from that Pitocin and let all of your receptors kind of reset and then continue on again. I don't want you to be so gung-ho and ready that you just want to keep pushing through, because we want to make sure that we're gently encouraging the body to go into labor and that we're giving your body a time to rest and reset if that is what your body needs. It might take several days for your induction process to result in labor that ultimately results in the birth of your baby. Hopefully it's not that you're in excruciating pain for several days. Of course we don't want that. That would be a really drawn out labor. But often maybe you're feeling a little cramping, a little something, but not a whole lot for a few days before things get started. So I think it's really important to be eating during this process. This is supported by the evidence, although some hospitals don't support it. Definitely something you can advocate for yourself to make sure that you're eating during this induction process, because the muscle, the uterus, needs food to do its job. You might have a really short induction process, but if it's longer, know that that is well within the realm of normal too. Another thing that can be well within the realm of normal, this is kind of wild and this is kind of crazy. If we have an induction where we have done many things and nothing has brought upon labor as we would hope, depending on what's going on, if it's an elective induction or a medical induction and how urgent that medical induction is, and your water's not broken, this is the most important caveat, and this is why I really encourage us to wait to break the water. We can actually stop the induction and send you home. Whew. That feels big and heavy. That feels really discouraging, right? But when we do this and we give your body a little bit more time to get ready for the laboring process, you might go into labor on your own or come back in a few days and we have a successful induction that leads to that outcome of vaginal delivery that we were hoping for. Sometimes your body simply is not ready. And so if your water's not broken and if that medical indication isn't we need this baby out yesterday, then that can definitely be something to discuss with your provider. Some people will call this a failed induction. Y'all know I don't like the F word in labor unless it's the literal F word. And in that case, it is my mantra. We don't fail at anything in labor. You can't fail at labor. But sometimes we need to pause and reset. So that sometimes is an option and something to discuss with your provider if we've tried many different medications and many different things and our body isn't responding in the way that we had hoped. Because remember, your body has 2 jobs: to keep you pregnant and to keep that pregnancy safe, and then to go into labor. And when we're doing an induction, we're meeting your body over here and we're trying to get it to go over here. It can take a little bit of time, and that's really normal. but sometimes it also can be good if we give it a chance to reset. So going from that, again, this part with patience is key. I want to talk a little bit about manual induction process. So this is either using a Foley bulb or a Cook's catheter that is inserted through your cervix that is open a little bit to put some pressure on that cervix to make it open. And often, depending on how much fluid is inflated in the balloons that's putting pressure on the cervix, we see that catheter fall out between 3, 4, and 5 centimeters of dilation, which is exciting, right? You're like, this is labor, it's getting started. And then a couple hours later, you're still 4. And a couple hours after that, you're still 4. And you're still 4, and you're still 4, and you're still 4. And you're like, what in the world is happening? When we use manual dilation to get labor started, often we have a pause at that level of dilation for a little while until your body catches up and brings the baby down, increases its natural oxytocin release, and starts to dilate the cervix. But I always tell my patients, okay, we're gonna be 4 and we're gonna be 4 for a while, and I don't want you to be discouraged. This is what we expect to see. The other thing to talk about is when we're adding Pitocin, eventually often our body takes over. So our goal is once you hit active labor to start coming down on that Pitocin, if we're able to and the contractions continue, and eventually even to take you off of Pitocin. So most people need about 8 milliunits of Pitocin to kind of get labor started. Obviously everybody's a little bit different. The other day I went way above that. But once my patient kicked into labor, we were able to bring that down, and I believe they even turned it off before the birth of her baby, because that is our goal, is to let your body take over and to let your bodies do its thing. We are trying to nudge you into labor, and then once your body takes over, we're like, okay, goodbye, love you for that. So it really is evidence-based and encouraged by ACOG that we come down on that Pitocin after your body naturally kicks into labor, and we hit that 6 centimeters of active labor to try and bring the Pitocin down and let your body do its own thing. Of course, when we're talking about labor, we have all of our P's, right? The power, the psyche, the passageway. But what's really, really important to know with induction, just like with any time in labor, fetal positioning is incredibly important. So during the induction process, I encourage you to ask your providers, where is your baby? Where is their head? Where is their back? Ideally, we want to get baby over to the left side. So Gilligan's Guide, spinning babies can be great resources on different positions if your provider doesn't have any to suggest, but chances are your nurse is going to put you through a whole bunch of different positions to optimize fetal positioning. An artificial rupture of membrane might be something that they do in the induction process to continue to get labor to progress. But I really encourage you to make sure that your baby is in an optimal position. So ideally on the left side and either facing your hip or facing your back before we do any sort of artificial rupture of membranes. And ideally that labor is pretty well established, that we are getting close to that 6 centimeters active range, because once you break your bag of water, you are in it. And once we break the bag of water too, sometimes it's really hard to correct any fetal positioning that may encumber labor or make your baby have some dips in their heart rate due to the positioning and the pressure on their vagus nerve. Once fetal positioning is optimized, that is another great way that your body often takes over the laboring process on its own once we've gotten things started in the induction process. The last thing that I want to let you know about the induction process, or about inductions in general, is that a lot of times people will give you a whole host of things that you can try at home to help get labor started. Maybe like sex, or eating pineapple, red raspberry leaf tea. All of these things don't have much evidence to suggest that they are beneficial, that they really will get you kick-started into labor. But many of these things also don't have risks associated with them. You can always ask or check with your provider to make sure, hey, how does red raspberry leaf tea sound if I'm drinking that at the end of my pregnancy to encourage a toned uterus? If you want to have sex, if that feels good or right for you, do it. Don't do it because somebody told you that it's going to put you into labor. But feel-good hormones are always a great thing. A little bit of prostaglandin from semen maybe is going to kick you into labor. But just know that there might not be a bunch of evidence to support that they actually work. If you're going to add any at-home natural induction things, to check with your provider. Some of them do have some risks, so we definitely want to make sure that you are having clear, open lines of communication with your healthcare provider before doing anything. I hope those 10 things were helpful for you going into the induction process. So all things to consider. And until next time, bye guys.